For the next session, Transformation of Management for H. pylori infection and gastric cancer, it is my privilege to introduce you to both of our moderators for this session. Our first moderator needs no introduction, Professor Varocha Mahachai. She's now served as a committee member in various international societies, council members, Chairman Award Committee of Asian Pacific Gastrological Association or APAGE. Dr. Mahachai also serves on an editorial board of Helicobacter and JNM. In addition, she is a corresponding fellow in Asia for the European Helicobacter Study Group and also a member of WGO Governing Council, Chair on Promotion of Education in the Asia Pacific region. And our second moderator also needs no introduction. Professor Andrew Chan is a gastroenterologist, the Daniel K. Podolsky Professor of Medicine at Harvard Medical School. Please give your warm welcome to both of our moderators, please.
Thank you. It's my pleasure and honor to moderate this session with Dr. Mahachai. I'm very grateful to be invited here to this beautiful country in Thailand. I always enjoy my visits. So without further ado, let me introduce our first speaker. Our first speaker is Professor Yeong Yeh from Malaysia. He's a professor of medicine and consultant of gastroenterology at University San Malaysia. He has authored more than 300 papers in high-impact journals, including Gastroenterology and Gut, several book chapters and textbooks, and is listed in Stanford's top 2% in the world in their respective field. He will be speaking today about H. pylori infection and gastric cancer, a 2024 update.
Right. So, good morning, and I'm really thankful for the kind invite to speak in this really exciting meeting. I was here last year, and this year I was tasked to give an update on how Helicobacter pylori infection and gastric cancers. Now, I would say that this is a rather interesting title I was given. And the first thing that we can be sure of is that Helicobacter pylori is still the #1 cause for gastric cancer. But how does Helicobacter pylori interact with some of these emerging risk factors or even microbiome will be the key to understand the carcinogenesis. So I was thinking these are probably some of my thoughts trying to condense into the next 15 to 20 minutes. What could be other emerging risk factors that may interact with Helicobacter pylori in gastric carcinogenesis? And giving some experience from our own country on addressing this question is having a dead or eradicated or a population with very low prevalence of Helicobacter pylori, what does it feel like to live in that world? And lastly is, how does microbiome interact with other gastric factors, including Helicobacter pylori in gastric carcinogenesis? So gastric cancer remains a significant public health hazard. We know from the Global CAN database that gastric cancer is the 5th most common cancer and the 2nd most common cause of cancer death. We know Helicobacter pylori is the class 1 carcinogen with more than 500,000 cases of gastric cancer attributed to Helicobacter pylori alone in 2008. 5% of cancer cases worldwide, and East Asia accounts for more than half of new gastric cancers. So I wrote this review article quite a number of years ago. And if you were to look at this map, you notice that there are certain populations where Helicobacter pylori infection, high prevalence correlate with high gastric cancers. And those are labeled in red, including the countries I mentioned early on. But there are also countries where Helicobacter pylori infection is high, but gastric cancers are low. These countries is what we call the paradox or enigma, for example, in India. So there could be other environmental or lifestyle factor that may be a reason. And in this review, we try to look at what are those strong risk factors and also intermediate risk factors. We know that smoking and salt are the strong risk factors, and alcohol is a risk only when heavily consumed. Likewise, red meat, high fat, this increase the risk, but fresh fruits, vegetables, and certain micronutrients reduce the risk. There's also some other emerging risk factors include obesity, Epstein-Barr virus, even dust, iron, and radiation, but those are just account for very small amount. But our world is constantly changing. There's always going to be emerging risk factors. And now one of the topic would be climate change, pollution, like what Ting Leong has mentioned about green endoscopy. Our group actually did talk about the first group that really detect microplastics in human colectomy specimens. And this was the publication on every single colectomy specimen that we collected. There are presence of microplastics. In fact, microplastics are so ubiquitous. It can be present in drinking water, in the seafood that we eat, even in beers and salt. So on average, we may be consuming almost 1,800 of plastic particles every week just from the water alone. And more recently, we have published this scoping review because there are more and more evidence that microplastics actually present in many tissues and organs. Not just that, but also in biological samples, including urine and also fecal samples. And the entry point can come not just from your seafood, it can come from the drinking water and even the air that you breathe. And there is emerging evidence that microplastic can be found in various cancer tissue, not just in the colon, but elsewhere, including breast cancer, gastric, and also pancreatic cancers. Now, if you look at more recent evidence, there are not a lot out there, so this is definitely an emerging research that we all should think about. And there are some emerging evidence that microplastic can definitely disrupt cell function, leading to carcinogenesis, and may also impact resistant therapy in gastric cancer. So I'd like to just put forward that this can be an emerging risk factor for gastric cancers. And at this moment in time, we don't even know how it may potentially interact with Helicobacter pylori and other organisms in the stomach. So something to ponder and to further research on. So second, food for thought is how we can learn from a paradoxical low prevalence population. Now, this particular meta-analysis clearly shows that eradication of Helicobacter pylori can prevent gastric cancers. If we were to compare between eradicated versus eradicated, it certainly favors eradication therapy, and a more successful eradication again favors the prevention of gastric cancers. Now, the paradox is that there is certain population where we find unexplained low prevalence of Helicobacter pylori, and I happen to come from that particular region. It was first reported in 1994 by my colleague Mahendra, where we only found less than 5% among 500 blood donors with Helicobacter pylori, and 5% among patients with gastric ulcers, and the ulcer perforation rate was only like 1 out of 100,000 person years. This was really small in numbers, and it really put our surgeon out of work. They don't know how to manage patients with perforated ulcer just because we don't see ulcers at all from the region where we are from. And this somehow more common among certain ethnic group, the Malay ethnics. And then this particular study was then repeated in 96-97 and showing the same trend, no change at all. Whereas the aborigine, who obviously had a poor hygiene, they would have a higher prevalence of Helicobacter pylori, but even them, when they migrate to the coastal region where they have a better hygiene, then the Helicobacter pylori prevalence would also reduce. And not just peptic ulcer disease, we also reported the lowest gastric cancer prevalence in the country, where only 9 cases were reported between 1994 to 1999. Now, interestingly, is we also reported a low prevalence of childhood asthma, and this is somewhat counterintuitive against what we term as the hygiene hypothesis. Now, there are other GI conditions that we have found an association with Helicobacter pylori. And again, one of the contentious association is gastroesophageal reflux disease. And in our population, we found that Helicobacter pylori is inversely correlated with high junctional cancer, but we did not report that in our series. We actually found a lower incidence of reflux esophagitis and also Barrett. You can see here 3% and less than 1% respectively. Likewise, we would expect, if say there is an inverse correlation, we would expect a higher rate of esophageal adenocarcinoma, but this is not what we found in our population. There may be an increasing prevalence of junctional cancer, but this is more likely due to obesity rather than due to Helicobacter pylori. Now, the next question we ask is, why does this population unique? What makes it unique? So the causes are probably multifactorial, we are not sure, but there are certain environmental factors that may explain this based on our studies, where this particular population tend to eat more antimicrobial diet. For example, Budu and Begaga, both of these food, they have antimicrobial properties and also probiotic properties, and as well as prebiotics. We also found that as you have better water and hygiene, you would have a lower transmission rate. And one of the important transmission medium for Helicobacter pylori is through water. Also, in this particular population, the absence of virulent factors and presence of protective gene polymorphism seem to play a part as well. Of course, we cannot run away from gut microbiome. The core infection with protozoa tend to worsen the gastric pathology, but if you have a core infection with helminth, it can be potentially beneficial. In our population, we also realize that there's a high prevalence of helminth infection among our children in that region, and this could be a reason for the low Helicobacter pylori infection in this particular population. Now, you imagine if you are in a world without H. pylori, this is what you're probably going to observe. You're going to have low rates of peptic ulcer disease and gastric cancer. It may not protect you from bronchial asthma, but it does not get you more GERD complications. And the reasons or why that can happen may be multifactorial, but certainly environmental and more recently gut microbiome may play a role. So now come back to the question, how does microbiome interact with Helicobacter pylori in gastric carcinogenesis? We have heard some fantastic talk from Francis and Craig on microbiome and probiotics. We actually And now we understand more that microbiota interact actively with the ruminant environment and is critical in maintaining the gut-brain health. And many often, the ruminant environment in the gut is shaped by the meta-exposome, meaning what are the exposure factors towards influencing gut microbiome, and one of the most important factors will be diet. So we are very interested in looking in a traditional Asian diet where we know in a way similar to the Mediterranean diet is actually have high fiber and also high functional foods. And because of this, it does help to promote beneficial microbiota, especially like Prevotella, and production of good metabolic byproduct like butyrates. And we do have ongoing studies from our group looking into how by applying a diet like an Asian diet, high in fiber and also functional food, how does it help to reduce infant food allergy when prescribed to a mother, a pregnant mother. Of course, more interestingly is about the gastric dysbiosis and carcinogenesis. We all now know, beside the Helicobacter pylori in the stomach, there resides microbiome. May not be as rich as in the small bowel or in the colon, but definitely there exists microbiome in your stomach. In gastric cancer, it has been found that this microbiome tend to have a reduce in diversity and richness. And two of the most evidence and enriched pathobionts in gastric cancer would be Streptococcus aeruginosus and the Epstein-Barr virus, as denoted in this particular diagram. So I heard the lecture from Professor Yeong Yeh from Hong Kong, and she gave a fantastic overview on how this Streptococcus aeruginosus, which is an emerging pathobiome that all of us would need to know if you are working in this area of gastric cancer and the gut microbiome. And in this particular review that she has mentioned, that the pathobiome, the aeruginosus, and even the Epstein-Barr virus can promote the tumoric genesis through interaction with the host cells and regulation of the tumor microenvironment. But how the microbial metabolites from all this microbiome are still unknown and definitely requires more research. Again, Helicobacter pylori can induce notable gastric dysbiosis and can be restored by eradicating the Helicobacter pylori itself. Of course, we heard about the probiotics, the conventional probiotics like lactobacillus and bifidobacterium. This can potentially also restrain the harmful effect of Helicobacter pylori. And since we understand there could be a potential microbial signatures, including Streptococcus aeruginosus, some of these signatures can be potentially developed even from oral gastric mucosa or even intestinal microbiota, but that remains unknown in terms of their efficacy, exactly like what Francis has mentioned in his lecture. And definitely, we all know some of these short-chain producing bacteria can enhance the therapeutic efficacy and help to alleviate some of these treatment-associated adverse events in gastric cancers. So definitely, I would think that there are really emerging evidence, especially for chemical pollutants like microplastic being a risk factor for gastric carcinogenesis, and how Helicobacter pylori interact with microplastic in the human microenvironment of the stomach remains a potential research in the future. Now, if you were to have a low prevalence population, we know the benefit on the fatty ulcer disease and also on the gastric cancer. So probably at this moment in time, a dead Helicobacter pylori is still the best Helicobacter pylori. There is an emerging evidence for microbial dysbiosis in gastric carcinogenesis. and how Helicobacter pylori interact with this microbiome and how it helps in treatment modulation will be, again, a great research area to look into. So with that, I thank you very much and look forward to questions. Thank you.
Thank you very much.
Introduce a second speaker, Dr. Thi Hanh Nhu. She's from Ho Chi Minh City, I believe, in Vietnam. She will speak to us today on antibiotic resistance and clinical translation for Helicobacter pylori infection, which is a key to eradication success. So please welcome Dr. Thi Hanh Nhu.
Good morning, everyone. I am Dr. Thi Hanh Nhu from Department of Internal Medicine, University of Medicine and Pharmacy at Ho Chi Minh City, Vietnam. Thank you very much for your invitation to attend this special ASEAN Gastro 2020, and I'm very honored to be here to present the topic antibiotic resistance and clinical translation for Helicobacter pylori infection. Today, my topics include the prevalence and antibiotic resistance of S. pylori, antibiotic susceptibility test for Helicobacter pylori treatment, and real-life practice and guidelines in ASEAN. First of all, I will talk about prevalence and antibiotic resistance of Helicobacter pylori. And as you see in the left figure, the Helicobacter pylori prevalence in ASEAN ranges widely from 20% to about 70%, in which Vietnam, Myanmar, and Laos have the highest Helicobacter pylori prevalence. And as you see in the right figure, the age standardized incidence rate of gastric cancer in ASEAN also range widely from about 1% to about 50%, depending on Helicobacter pylori prevalence. Therefore, the Helicobacter pylori eradication is recommended to prevent gastric cancer. However, the main obstacle to successful eradication is increasing antibiotic resistance. And Helicobacter pylori resistance has reached alarming level across the world, especially in ASEAN. And this table shows the pattern of Helicobacter pylori antibiotic resistance in ASEAN. And for tetracycline and amoxicillin, the highest antibiotic resistance rate is highest in Vietnam. And for clarithromycin resistance, the resistance rate is highest in Vietnam and the Philippines. Resistance to levofloxacin show a wide range with the highest rate in Cambodia and the Philippines. The resistance to metronidazole is really high in across the country in ASEAN, with the highest rate in Cambodia and Myanmar. And the multi-rot resistance was extremely high in Cambodia and in Vietnam. The emergencies of multi-rot resistant Helicobacter pylori is caused the public health threat. So a systematic review reported the prevalence of primary antibiotic resistance, and 15 studies were included and were published between 2011 and 2020. And as you see in the table, in Thailand, the multi-rot resistance rates range from about 4% to about 22%. And in Cambodia, the MDR rate is extremely high, with about 7%. And in Malaysia, the MDR rate is lower, with about 2% to about 7%. And in Singapore, the MDR rate is also low, about 7%. And in Vietnam, the MDA rate is very high, about 51% for primary resistant and can be up to 80% for secondary resistant. Regarding the primary antibiotic resistance over time in ASEAN, in Malaysia, and you see the resistance to clarithromycin and resistance to levofloxacin increase gradually, and resistance to clarithromycin can be up to 15% recently. In Thailand, compared with the period 2004 and 2012, the resistance to clarithromycin, metronidazole, and multi-rust resistance was significantly higher during the period 2014 and 2021. And in Singapore, as you see in this figure, the resistance rate of clarithromycin also increased but slowly, and amoxicillin resistance seemed to unchanged. And therefore, the efficacy of triple therapy over 2 decades in Singapore also decreased but slowly. And in Vietnam, there has been a lambing primary resistance rate for amoxicillin across Vietnamese study, and the results show that primary resistance strain to amoxicillin in adult patients was about 25%, and in children, the primary resistance was also very high, about 25%. The resistance to clarithromycin and levofloxacin also very high in Vietnam at about 81% and 53% respectively, and the dual resistance was observed in 48%. Therefore, the eradication rate of trouble in Vietnam decreased dramatically during the period 21 to 2016. And let's move to the antibiotic susceptibility test for Helicobacter pylori treatment. The Maastricht CIS consensus recommended that it's reasonable to recommend that susceptibility tests are routine performed even before describing first-line treatment in respect to antibiotic stewardship. However, the generalized use of such susceptibility-guided study in routine clinical practice remains to be established. Molecular methods allow detection of Helicobacter pylori mutations associated with resistance to clarithromycin, levofloxacin, tetracycline, and rifampicin. And this is the 2 multi-center open-label randomized control trials compare molecule testing guided therapy versus traditional culture-based susceptibility testing guided therapy. And the results show that the eradication rates in molecular testing guided group and the susceptibility testing guided group were similar in first-line treatment and in third-line treatment. And the traditional approach should be changed to antimicrobial susceptibility testing also be recommended. And a traditional approach based on experience and leading to antibiotic misuse and low eradication rates. The ASD should use when the cure rate of imperial therapies is lower than 90% or after a failed attempt. Samples from gastric biopsy as used for culture or molecular testing, and stool sample was used for B-cell or next generation sequencing. And the results from ASD tests as used to guide regimen selection, avoid inappropriate antibiotic use, and improve eradication rates. A last population-based study was carried out in Thailand, and as you see in the figure, this is the green line. If the ASD was performed before first-line therapy, the eradication rates were significantly higher than in no ASD. And if ASD after second-line failure, the eradication rates also increase rapidly and become significantly higher after fifth eradication. Another large population-based study has just been published this month in Thailand. This study investigates the use of real-world evidence to generate cost analysis of ASD in patients with Helicobacter pylori treatment failure. And in this study, early ASD were defined as ASD performed shortly after first-line treatment failure. And the results show that susceptibility-guided therapy provided better eradication rate than imperial therapy in treatment failure group. Early ASD provided significantly lower total average cost of treatment than group without ASD and ASD after treatment failures. Early ASD group had lowest cost of subsequent medication, post-treatment urine tests, and hospital visits. Finally, I will talk about real-life plastic and guidelines in ASEAN. And we conducted the study to examine the real-life plastic of Helicobacter pylori management from 10 countries in Southeast Asia. And in this study, about 55% of participants are GI physicians, and the others are non-GI physicians. And about 52% of participants had at least 10 years of experience. And approximately 2/3 of participants work in public hospital or teaching affiliation. And this table shows the local resources of bismuth, BCAP, and ASD tests in Southeast Asia country. Based on the report of antibiotic resistance in Southeast Asia, we divided the countries into 3 groups. High clarithromycin countries included Cambodia, Indonesia, and Vietnam. And intermediate clarithromycin resistant included Malaysia, Singapore, and Thailand. And low clarithromycin countries included Brunei, Laos, Myanmar, and Philippines. And the results show that bismuth was more unavailable in low clarithromycin countries than in intermediate clarithromycin countries and high clarithromycin countries. Bismuth was more unavailable in low clarithromycin country and high clarithromycin country than intermediate clarithromycin countries. Regarding ASD tests, and we found that about 42% of participants reported that the ASD tests were unavailable in their clinical practice. And for the first-line treatment in countries with high clarithromycin resistant rates, and the most common regimen is the bismuth carbotherapy, PPI, bismuth metronidazole, tetracycline, but the rate was only about 58%. Alarmingly, about 28% of participants prescribed the PAC, standard triple therapy for patients, and its prescription was significantly higher than in non-GI physicians than in GI physicians. About the regimen duration and probiotic combination, there was no difference between non-GI group and GI group. And now I would like to talk about some guidelines in Asia. The Bangkok consensus recommended if the ASD is available, the regimen based on the test. But if the ASD is not available, the regimen based on the best locally available. And the first-line treatment vary regionally depending on pattern of ASD in each country. If clarithromycin resistance standard tribal therapy for 14 days may be useful. And the second line regimens, we will use antibiotic not used previously or resistant is unlikely. And in Vietnam, because the resistance to amoxicillin and clarithromycin is very high in Vietnam. And the Vietnam Association of Gastroenterology consensus recommended that the first line regimen is bismuth carbotherapy, PI bismuth metronidazole tetracycline, and the alternative first line regimen is PI amoxicillin, levofloxacin, and bismuth. The second line regimen is PALP or PPMT if it has not been used in first line regimen. If two failed eradication attempt, AST test should be performed, and the rescue regimens we should use P5 plus 2 sensitive antibiotics with no prior history of allergy. And some strategy to overcome Helicobacter pylori resistance consists of optimized eradication therapy, such as locally effective treatment of regimens depending on regional susceptibility patterns. Bismuth carbotherapy in regions with like clarithromycin resistance, adding bismuth to conventional regimen, tailored therapy or BCAP-based therapy. Adjuvant therapy should be used with probiotic or anti-biofilm agents. In conclusion, the increasing frequency of antibiotic-resistant strain, especially emergence of multi-resistant bacteria, is a major challenge in ASEAN. The treatment strategy mainly depends on the availability of AST, the local antibiotic resistance rate, especially the clarithromycin resistance rate, and the local available of bismuth. Choosing inappropriate regimens containing antibiotics with high resistance rates is not uncommon in ASEAN, especially among non-GI physicians. Therefore, minimizing the resistance rates to currently available antibiotics is urgent in ASEAN. Thank you very much for your attention.
May I ask a question? Dr. Thi Hanh, I noted the resistance in Vietnam are quite high with the clarithromycin and levofloxacin. So you're probably facing primary eradication failure. So what are your options for rescue therapy for the secondary or tertiary eradication? You have any suggestion? What regimens would you use instead if there's a failure?
Yes, thank you very much for your question. So we also conducted some studies about the efficacies of sequential therapy or concomitant therapy among Vietnamese population, and the results is not good, and the efficacies between the sequencing therapy or concomitant therapy is lower than the bismuth carbotherapy. So we built the guideline for Vietnamese population based on the evidence in Vietnamese population, and now we don't recommend to use the sequencing therapy or concomitant therapy. And the first line should be used bismuth carbotherapy.
Right. And what about PCAP regimens?
I'm sorry, the BCAPs now is not available in Vietnam, so we cannot use PCAP in Vietnam. Yes.
Thank you very much. So our next speaker is Professor Jantown Lin from Taiwan. He is currently the Vice Superintendent at Ida Hospital in Kaohsiung, Taiwan. And he's a physician scientist, endoscopist, gastroenterologist and hepatologist who has been actively involved in basic clinical, epidemiological, and translational research in peptic ulcer disease and H. pylori infection. He will speak today about best therapy for H. pylori infection.
Thank you, Mr. Chairman. First of all, I would like to express my sincere thanks for the organizing committee to invite me to participate in this important meeting. It's a privilege for me to come here. And the topic I will present is the best therapy for Helicobacter pylori infection. I'm Zhao Tang Lin from Taiwan. And the topic I will present is the best therapy of Helicobacter pylori infection. First of all, I have to define what is the best, because that I don't know for anyone they will define as the best. So first of all, we have to define what is the best. Maybe today we cannot make a conclusion for what is the best for everyone. And then we talk about the factors may affect the eradication rate, adverse reaction, and compliance. And then we talk about the first line, second line, third line, and make the conclusion. First of all, how to define the best therapy? I think that the best therapy must consist of three factors. Number one is the highest eradication rate, the efficacy. The higher, the better. The number two is the lowest adverse effect, the safety. The third one should be compliance. So we talk about the first-line therapy. There are three kinds of combination for the first-line therapy. The dual therapy consists of two drugs. Traditionally, we try to use the PPI plus amoxicillin. This is a traditional dual therapy. Now we have advanced by using the vonoprazan, the PCAP. And even we found that some of the study for the high dose vonoprazan plus amoxicillin can get a very good result. Then we talk about the triple therapy. The triple therapy consists of three drugs, PPI plus clarithromycin plus amoxicillin. It's a traditional classical triple therapy for H. pylori infection. Now, we also find some new advance for the vonoprazan plus clarithromycin plus amoxicillin for the new triple therapy. And then the quadruple therapy has been widely used. They consist of four drugs. There are some containing the bismuth, some did not containing the bismuth, so-called the concomitant therapy. Now, we are going to move to the factors which can affect the eradication rate, adverse effect, and compliance. There are a lot of factors may affect. Number one is the optimal time for treatment. The number two is the potency of the acid suppression. Number three is the optimal number of the drugs, dual therapy, triple therapy, or quadruple therapy. The order of the medication are given, or sequential or concomitant, may affect the factors. Also, and most important one is the antibiotics resistance, as previous speaker has mentioned. Now, availability of the bismuth is another question. So, the bismuth containing or non-bismuth containing therapy also one of the factors. Now we're moving to the optimal treatment of this. As shown in this slide, in previous study, you can find that the treatment for triple therapy must be given for 14 days because that 10 days, 7 days are quite not enough. The second one is how potent is the acid suppressor. Traditional classical PPI or higher dose PPI. The results showing the higher dose PPI may be used to increase the eradication rate. So we must suggest the high dose PPI. And the order of 4 drugs are given. In the lower panel, you can see the sequential therapy. The sequential therapy is given for the day 1 to day 5 with a PPI plus amoxicillin. In day 6 to 10, they will give the PPI plus metronidazole plus clarithromycin. This kind of sequential therapy is compared to the concomitant therapy or bismuth quadruple therapy. This is a comparison between sequential versus triple therapy for the first-line treatment. This study compared the sequential 14 days, sequential 10 days, and triple therapy for 14 days. They found that sequential therapy for 14 days is superior to triple therapy for 14 days. And then we do another study to compare the concomitant bismuth quadruple and 14-day triple therapy. And the same, the results showing 10 days bismuth quadruple therapy, but not 10-day concomitant therapy was more effective than 14 days triple therapy. This is a network meta-analysis to compare all kinds of therapy for the first line for Helicobacter pylori infection. As shown in this slide, you can see that there are non-bismuth quadruple therapy, bismuth quadruple therapy, this kind of therapy, or the 4-drug therapy. In comparison to the 4-drug therapy, there are new potent acid suppressor, the PCAP, the vonoprazole-based triple therapy. This study showing that the result shows vonoprazole triple therapy had the highest efficacy. The new and potent acid suppressor does work. Now we're moving to the antibiotic resistance. There are a lot of antibiotic resistance, including the metronidazole, clarithromycin, and levofloxacin. This slide is the update knowledge about published in Lancet 2024. We have collected all the primary antibiotic resistance of Helicobacter pylori in ASEAN Pacific region between 1990 and 2022. As shown in this slide, you can see that the antibiotic resistance rate increased progressively in everywhere in every country, and year by year, up to year 2022, the metronidazole resistance rate up to 61%, levofloxacin 35%, clarithromycin 30%. However, the amoxicillin and tetracycline resistance rate was quite low, very low. What is the meaning of the antibiotics resistance? We can show you the slide that how can predict the 4-drug therapy is better than 3-drug therapy. If we use the people or the person who coming from an area with a very low clarithromycin resistance. For example, like the clarithromycin resistance prevalence is about 20%. Then you can see the eradication rate of 4-drug therapy, the quadruple therapy, and the 3-drug therapy, the triple therapy. When the prevalence rate, the resistance is less than 20%, then there is no difference between the 4-drug therapy and 3-drug therapy. So the result here showing triple therapy still sustain a high eradication rate if clarithromycin resistance is low. How about the recent antibiotics resistance in ASEAN Pacific region? This is the most updated data. For example, in Thailand, we can see the clarithromycin resistance is ranging very wide from 0 to 100. The median is 7%. And the metronidazole resistance strain is about 44%. This kind of low clarithromycin resistance, but a high metronidazole resistance strain, showing this trend not only in Thailand, but also in Malay, in Singapore, in Taiwan. This is the so-called the low or median resistance for the clarithromycin. In contrast, in China, you can see that the clarithromycin resistance rate is about 37%. And this condition is similar in Cambodia, in Pakistan, and in Vietnam. So the best first-line therapy for Helicobacter pylori infection for people living in a low clarithromycin resistance, such as in Thailand, in Taiwan, in Singapore, in Malay, PPI with triple therapy still works. If not, you can use the vonoprazole triple therapy or bismuth quadruple therapy. But classical PPI plus triple therapy may get a better eradication rate. In contrast, region in clarithromycin resistance, there will be no chance to use the clarithromycin. Therefore, you should start for the first line with the bismuth quadruple or non-bismuth quadruple, depend on availability of bismuth in your country. Recently, vonoprazole high dose with dual therapy had a good study for the first-line therapy for Helicobacter pylori infection. How about the second-line rescue therapy? Traditionally, we have 3 choices. Number 1, use the bismuth quadruple therapy. Number 2, use the quinolone-based triple therapy, especially the levofloxacin has been widely studied. And number 3 is the ribabutin-based triple therapy. Therefore, the Maastricht and Florence consensus report suggests when patients living in the region with low clarithromycin prevalence, then you can start the classical triple therapy with clarithromycin. But if the first-line therapy fails, you should treatment with a bismuth quadruple or levofloxacin-based triple therapy. And if you live in a region with a high clarithromycin resistance, then bismuth quadruple or sequential or concomitant can be used. The rescue still using the levofloxacin-based triple therapy. They concluded that the PPI levofloxacin amoxicillin triple therapy or bismuth quadruple therapy are recommended as the second-line rescue therapy. Moreover, we have something new for the second-line rescue therapy. That is the PCAB, the potent acid suppressor vonoprazole. As shown in this slide, you can see that in the vonoprazole dual therapy or monoprazole triple therapy, they had a better result than that of the lansoprazole-based triple therapy. Moreover, if the patient has a clarithromycin-resistant strain, the difference between the vonoprazole therapy and the lansoprazole therapy get more and more significant. So they found that high efficacy in vonoprazole dura and triple therapy, especially in clarithromycin-resistant strain. This is a meta-analysis of any kind of vonoprazole versus PPI for H. pylori eradication. They found that vonoprazole-based therapy was superior to PPI-based therapy for H. pylori eradication, especially in patients with clarithromycin-resistant strain. How about the treatment failure after the first time and second line therapy? Now we consider the third line treatment. Before the third line treatment, we should consider how to define the bacterial resistance by using the culture sensitivity test, the SAT test, AST test, or use some molecular method to define the antibiotics resistance. There are two ways to detect the susceptibility test guided therapy. One is the traditional, the culture, MIC, and agar dilution method. The other one is the molecular method by PCR direct sequencing. They use the 23 ribosome RNA for point mutation for clarithromycin resistance, for GRAS A mutation as a guide for the levofloxacin resistance. This slide shows that to compare this kind of two tests, molecular method or culture method, they found it the molecular method is not inferior to the traditional susceptibility test. However, not everywhere had this kind of culture method or molecular method. So we compare the empirical therapy. That means that once you use the antibiotics failure, then you don't use it again. Then we can compare two tests, and the results show the eradication rate between two tests was similar, almost 78%. So the third line therapy should consider the genotypic resistance guide therapy as empirical therapy can be used. And molecular method is an effective alternate for the susceptibility guiding test. So Maastricht 5 consensus and Toronto consensus also suggest that both methods can be used for the third line. However, the evidence is very low because that the recommendation is also weak. So, dear colleagues, the first line therapy should be used in triple therapy can be used in the low clarithromycin resistant area. But in high clarithromycin resistant area, you should consider the quadruple therapy, either bismuth or non-bismuth. And second therapy, use the bismuth quadruple, quinolone, and ribabutin-based triple therapy. If the first line and second line fail, you should consider genotypic resistance guiding therapy. If not, you can try the empirical therapy in the third line therapy. The last slide showing it is crucial to tailor the treatment regimen to the individual needs, considering the factor as the optimal treatment length, the number of drugs, the order of medication administration, and the patient's specific antibiotics resistance profile. Thank you for your kind attention. Thank you.
Thank you very much. Can you speak a little bit about adherence and of the different regimens in terms of what is more acceptable to patients in terms of, the bismuth-based therapy, non-bismuth therapy, PCAB, dual versus triple?
There is no such a kind of head-to-head comparison, but we have corrected all the meta-analysis, and also because that in different country, in different area, they have the limitation for the accessibility of the sensitivity test, and also they have the availability for the bismuth, and also the PCAB. They are not every country, every region had the same situation for the drug they had and the test that they had. So it's very hard to compare. So I said there is no best way, because you have to so-called the precision medicine based on what kind of people you have, and also where you live, and what drug can you get, and what test can you have. So it's very hard to answer the question in one short term.
There's a question from the audience.
Dr. Simon?
Thanks, that's very interesting. Simon Travis from Oxford. In this era of mobility, people move around. Do we know anything about the age at which antibiotic resistance is acquired? Is it in childhood that Helicobacter resistance is, that antibiotic resistance or Helicobacter is acquired? Or is it later? Does it all depend on where the patient is brought up until the age of 5 or something?
Yeah, it's a tough question, but the majority of the patient, if after the first treatment, first eradication therapy, then we have found that if the eradication is successful and the reinfection rate is not so high, so the majority of the patient get the H. pylori infection is usually at the age of childhood or even adolescent. But after the eradication, they work hardly to get Helicobacter again. But the resistance to different antibiotics may be required, may be acquired during their childhood or during their adulthood, because that, for example, the metronidazole is the #1 drugs. They had a lot of high resistance in everywhere, especially in ASEAN, because that they usually being used for the other indication, not for the Helicobacter, but for the vaginal infection, for the common parasite infection, the metronidazole. However, this kind of antibiotics has been used before. Then when you got the infection for the Helicobacter, you try to use the metronidazole. At this point, the metronidazole will not work. So the kind of the metronidazole resistance is coming from the previous exposure by other indication. But for clarithromycin, it's not easy to get in some countries, especially in Singapore, in Taiwan. We have very strong limitation and restriction to use the clarithromycin and also for the levofloxacin. However, in some countries, maybe in other countries, you can find that they can easily get the clarithromycin and even levofloxacin. So that's the acquired antibiotic resistance is coming from the secondary use.
So you can't just decide on where the patient was born and lived their first few years. You still have to do antibiotic testing if you have unsuccessful third-line eradication therapy. Thank you very much.
Thank you.
So we also just have a few minutes for panel discussion if anybody has additional questions for any of the speakers. If I could just pose one question to Professor Lee. I was very interested in your discussion of the microplastics hypothesis. I was curious if you have been thinking about other opportunities to assess exposure to microplastics besides looking at the tissue. Is there other biomarkers of exposure in the blood or other areas that you can use to compare people and their relative exposure to microplastics?
Thanks, Andrew, for that very interesting question. I do believe microplastic research is still very new. It's just people are getting interested. There's some awareness, but not many understand or know how to do further research in this. And there's so much thing that we do not understand, how microplastic interact with the tumor microenvironment, how it interact with microbiome, or even how it affects the inflammatory pathway. We are still very early in microplastic research. For now, if you look at the literature, most are looking into epidemiology, like what tissue get exposed to microplastics, where is it found. And one of the paper that I collaborate with colleagues in the US, under the University of Washington, we found even a difference between microplastic exposure in the US population and also in the Asian population. So I think we are more excited on the epidemiology side of things, but I do recognize your thoughts on how this, I think in vitro we do need more studies trying to understand the relationship between microplastic and also the other biomarkers. One thing that I want to highlight is that microplastic itself may not be the agent. It can be just an agent. It can be a carrier for vectors. For example, we have some early data showing that plastic itself may carry pathogen, viruses, and so on, and that may be one of the reasons for causing a pathology in the tissues. And plastic itself can also have chemicals. It consists of polymers and other chemicals. But one of the well-known chemicals is bisphenol A or BPA, and it tends to be associated with polycarbonate, for example. So I do think there is a great potential for studies, and there are, I believe, emerging evidence that it could be an upcoming risk for gastric carcinogenesis.
Thank you. Francis?
Mr. Chairman, can I make a little announcement here? Well, as the Senior Associate Editor of the journal Gastroenterology, now I'm handling a review article on microplastics and the GI tract, and I'm desperately looking for reviewers. None of the reviewers so far agree to review this paper because they don't have any expertise. So maybe I'll take this opportunity to ask Justin or some of our friends here to review this paper for me.
Thank you, Francis. Well, with that, we will close this session. Thank you very much for the wonderful speeches. Thank you.